Welcome to an overview of autism spectrum disorder for community mental health providers. I'm Leona Oakes. I'm a psychologist with transitional care medicine and neuroscience at the University of Rochester.
Hi, I'm Susanna Idarola, another pediatric psychologist with developmental and behavioral pediatrics at the University of Rochester Medical Center, and we're excited to be presenting some information about autism spectrum disorder today. So we'll just jump right in. Autism spectrum disorder, which I will also sometimes use ASD to shorten it, is characterized by two primary symptom areas within DSM-5, and those include social communication skills, and then restricted repetitive behaviors or interests. And we're going to go through each of these symptoms areas individually and provide you with some examples of how that might look and present in individuals with autism that you would see in the community. So first we'll talk about social communication skills. And when we talk about social communication skills, we really mean aspects of relatedness, or how people are, how they act, how they relate, and how they connect with other people. With all of the symptom areas that we're going to talk about, it's important to note that obviously symptoms are going to look very different across the lifespan. And we really want to make sure that we're focusing on how these symptoms might evolve and shift, and how presentations of ASD might evolve over the course of the lifespan. Because I think that what ends up happening is a lot of how people picture autism is very much based on symptoms that show up in early childhood. And so as children naturally develop skills as they get older, they can still show qualitative difficulties in some of these areas in a way that still allows them to gain for skills, but will still fall under the criteria of ASD. So we're going to share a little bit about how those symptoms will change over the lifespan. The first symptom that we'll talk about is difficulties or differences in social reciprocity, or really just how people relate to each other, how the back and forth of social interaction shows up. In early childhood and really little kids, this starts very early as within 4 to 6 months, when you might assume to see children start to show aspects of joint attention. So are they going to look where you're looking? Are they going to show you things that they're interested in? Do they smile in response to your smile? I was just talking to a friend, and she was showing me through Zoom a video of her baby who's only 3 months old and already will smile when another person smiles at them. So some of these skills show up very early in life and can be obviously absent in children who might be at risk for autism spectrum disorder. When kids get a little bit older, toddler age, they'll start to do things like point at things that are interesting to them, like a car or a dog out the window. They might follow where you're pointing, and then they'll start to comment when you say things. So even kids who don't have a lot of language, if you say, wow, it's a dog, they might say dog, or they might say car. So there's an aspect of the back and forth. We don't see that as, sometimes it's completely absent in young kids with autism, and sometimes it's present but just not happening as frequently or with as high a quality as we might expect to see in typically developing kids. So when you don't see some of this affect matching, shared commenting, shared attention in early childhood, that could be a sign of an autism spectrum disorder. Some of these will transition to school-age kids, so there are some school-age kids who still are not sharing interests as much, who might not be matching affect, but then you also see difficulties with social reciprocity showing up in other ways. So for example, we often notice that even when kids start to develop language, they may have a hard time engaging in a true back and forth in conversation. They might prefer to kind of talk only about the things that they want to talk about, and so you end up with a little bit more of a one-sided conversation, or seem uninterested in kind of engaging in conversation at all. You might also see them develop a lot of interest, but not show as much interest in getting other people excited about what they're interested in the way that kids tend to do when they get older. And then you might also see some difficulties with empathy. So either not being able to identify the emotions of others, or noticing when others have big emotions, but not seeming to do things like offering comfort if someone is upset, or worrying about someone if they get hurt. So those are some of the ways that we start to see reciprocity differences emerge in school-age children. And then when you get to adolescence and adulthood, We do see some continued difficulties with things like sharing interests and reciprocal conversation. And then sometimes perspective taking differences, like not understanding that other people don't know what I'm thinking, that becomes more apparent in adolescents and adults. A lot of school-age children who are typically developing are very egocentric and don't seem to understand that like not everyone has a window into their thoughts. But when you get to adolescence and adulthood, that's a subtle social skill that people start to expect of you. And so when those expectations start to exceed the individual's ability to show perspective taking, you might notice this as more of a deficit than was apparent in earlier childhood. Leona, would you add anything to that?
I would. I think a lot of times when people have sort of gone undiagnosed for a long time, they often build a reputation in their families of being sort of not as understanding, and there's often a misconception in the family that that is purposeful, or they're not trying. And a lot of times when you talk to the individual, they are very confused because they feel like they're doing the best they can to understand others and to make their points clear. And there's just that mismatch constantly. And we see that a lot in people with autism who really want to do well socially, but are just missing it. We often call it on track, but off target.
Yeah, that's a great point. Thank you for adding that. Okay, we can move on. The second social reciprocity symptom that we look at is nonverbal communication. So all the ways that we try to share our experiences with others without using language. And you'll see the number one thing that kind of shows up across the lifespan is qualitative differences in eye contact. This can range from everything from like completely avoiding eye contact or a lack of eye contact to, on the other end of the spectrum, eye contact that might be overly intense and like doesn't kind of regulate very well, which might kind of feel awkward as the recipient of that intense eye contact. Or, you know, kids learn over time, because it's sometimes a target of intervention, that they do have to look at someone's face when they're talking to them, but it might not be sustained or, you know, shifted back and forth in the way that you would expect in a more natural social interaction. So we do see those differences in eye contact emerge across the lifespan. In really young children, you know, young kids have very like a limited range of facial expressions anyway, especially when they're toddlers. Like they're happy, they're upset, they're sometimes confused, they're angry, whatever it is. And so it's a little bit harder to distinguish subtle differences in facial expressions in very young kids. But what you might see is kids who seem to not really have a lot of facial expression. Their parents might describe them as kind of flat. Sometimes parents describe it as a little bit wooden. They don't seem to be having emotional experiences, which doesn't mean that they aren't actually experiencing emotions, but it doesn't show up on their face in a way that can clue other people into how they're feeling, which can be very difficult for a person who's interacting with them, because they might have this big emotional experience that you're not able to tap into. Really young kids start to do things like point and wave and clap and say yay, and they might learn some basic signs. And we do see some differences in how kids with autism develop gestures. They aren't using gestures generally in early childhood, and you might notice that that interferes with their ability to communicate, especially when they don't have a lot of language, which then can result in like some frustrating and challenging behavior, because there is no way for them to communicate. When kids get older, some of those differences in facial expressions and gestures will persist, but they can be a little bit more subtle. So for example, school-age children are expected to show a lot more range in facial expression. We look for kids looking surprised. They might look guilty. They might look sly. They might look amused. They might look embarrassed, right? Those are not facial expressions that we see as much in toddlers, but in school-age kids, we expect to see them. And so even kids who have ASD who might have had facial expressions in early childhood might not then go on to develop some of these more subtle facial expressions that you expect to see in elementary school kids. They might also have facial expressions that are still muted or kind of overly exaggerated even. And so again, it's not that the facial expression isn't present at all, but it's about the quality. Does it look natural? Does it look how you would expect it to look in a child of that age? Kids, when they get older, also may show some persistent difficulties with gestures. Like we talk with our hands a lot to help people understand what it is, what we're saying, and some of those might not develop at the same rate in school-age kids. And then in adolescents and young adults, you'll see some continued differences in eye contact and gestures. And then at this age, it's oftentimes difficulties interpreting nonverbal cues, not just producing them, but in understanding them in others might become more apparent, such as understanding personal space, or being able to recognize when someone's like, you know, trying to end a conversation or trying to shut you out of a conversation. Leona, I'll let you add anything if you'd like.
I would add to that that for some young adults, they'll kind of get a small toolkit of gestures that they really understand and get, and then they sort of overutilize them, where that becomes the gesture they use for everything. And you can see that they're definitely attempting to use nonverbal communication, but there just isn't that subtlety behind it where they can use different gestures on the fly. I feel like they've learned a few from favorite friends or trusted people, or maybe even in therapy and things like that. And so they just keep going back to that gesture over and over, rather than having different gestures depending on tone and mood and intent and those kinds of things.
I'm sure it's becoming clear to everyone that Leona is the autistic adult expert. Okay, we can move on to the next slide. Thanks. The last symptom area within reciprocity is play and friendships. And this is really just about relationships in general and how kids with autism and adolescents with autism may be relating to others. So in early childhood, you know, you're not making a ton of friends when you're toddlers in the traditional sense, but you do start to show interest in other peers, and you might want to follow them around or do things with them or imitate them, especially. And you also might, as a toddler, imitate adult actions, so that when you start to learn things like play, like peekaboo and games like that, that it requires social imitation. And so we might see less interest in engaging in some of those activities, less interest in other peers the same age. In early childhood, you know, basic pretend play skills do start to emerge, and we do see kind of pervasive difficulties with imaginative, dramatic play, either with toys or with other kids, that kind of persist throughout childhood. Kids with ASD sometimes tend to be a little bit concrete, and so the idea of pretending that something is something else doesn't quite make sense, because like, this block isn't a car, it's a block. And so that might interfere with their ability to engage in pretend play or other types of dramatic play games. And so we do see some of that start to emerge in early childhood, and then definitely continue in school age play. Like Leona said earlier, school age kids often might learn specific play routines, like they learn how to play superheroes or they learn how to play school, but they might rely a lot on like a particular script and do it over and over again, and not show as much interest in branching out into other play activities or other topics of play, or be able to take that script beyond like what they've practiced to build upon it in a natural way with other kids. And so that could be interfering as you get into school-aged years. That also can affect your peer relationships, right? Because that's how kids interact with each other a lot in elementary school, especially young kids. Everything happens through play. And so if you're not able to kind of keep up with the kind of play that your peers are engaging in, it's a little bit harder for you to develop relationships. Many kids with autism do have friends, right? And so they might have friends who they have shared interests in. Sometimes we do notice that like their friendships might be a little bit more based on parallel play. So we're both going to do the same activity together and be next to each other, but there might be less engagement, or there could be kind of joint interactions, but the relationship is really based on like one shared interest instead of a lot of mutual interests or mutual understanding, or in a reciprocal way that you might expect to emerge a little bit more at this stage. And then certainly in adolescent and young adulthood, we expect both peer relationships and romantic relationships to be very much based on reciprocity, shared interests, mutual understanding, mutual values. And so that back and forth, right, back to our first symptom area of reciprocity, like that might bleed into this area as well and make it more difficult for a person with autism to develop a meaningful two-sided relationship, either as a friendship or a romantic relationship. That is not to say that it doesn't happen. Many adolescents and young adults and adults with autism have very productive reciprocal relationships with peers and romantic partners. And so again, it's not like it's there or it's absent. It's just the quality or how it develops might be a little bit different.
And it's also very common for them to have those relationships, but fewer of them. So I feel like autistic adults tend to be I have a few very high quality relationships that are very important to me, that I put a lot of work in, that have been built up over time. And then they don't have the superficial friends and acquaintances. Or if they do, there's that acknowledgement of like, well, and that's where a lot of autistic adults do have that insight where it's like, well, I play video games with these 6 people, but really only one of them is my friend. And understanding that that deeper relationship happens with fewer people, and that's okay if as long as that sustains them and they're happy with that and satisfied with that, right? And then I do think in adulthood and in adolescence, we know that school age, that sort of emotional maturity waxes and wanes through development for everyone. But I think a lot of young people with autism find that they get their best friendships in high school and college, when it's a little bit more, when your quirks are more embraced. I feel like school age kids can be a little bit more like, that kid's weird, I'm not going to play with them. Whereas it can be easier to find your people in high school and college. And that's also where extracurriculars are really helpful for people with autism in their adolescence and in adulthood, because like theater can be where they find their people, or chess people can be where they find their people. And it's so important to set them up for groups, but then you might not see friendships outside of those groups.
Thank you. So those are the 3 symptoms that fall under social communication. And to qualify for a diagnosis of autism spectrum disorder, you have to show differences in all 3 of those areas. In contrast, we're going to move to the second symptom area, which is restricted or repetitive behaviors or interests. And kids have all kinds of weird, and adults have all kinds of weird behavior that we do, but there's a specific set of behaviors that we associate with autism spectrum disorder. And to qualify for a diagnosis, you have to show 2 out of these 4 symptoms. So I'll just really quickly, because these are overt symptoms, we can see them most of the time. And so I think that these people tend to be a little bit more familiar with what these symptoms look like. The first area is repetitive behavior. So that can show up as repetitive speech, including repeating quotes from movies or favorite TV shows, or repeating what they've heard other people say, either immediately after or after a delayed period of time. So you'll hear kids like, say something that they've heard their teacher say. I had worked with a family where there were 2 kids, 2 siblings, and the little boy who had autism would always tell his little sister, friends don't treat each other that way, because that's what his teacher would say at school. And so he was using that to try to like show her how she was supposed to act at home. So an example of delayed repeating speech. We often see repetitive motor movements. So the most classic sign that we think of is flapping hands. You might see kids posture their fingers in specific ways, or you might see whole body movements that involve things like rocking and positioning of the arms or legs in specific ways that kind of happen over and over again. Or there can also be repetitive use of objects, which includes using objects that aren't intended to be played with, like opening and closing cabinet doors over and over and over again, or using toys, but in not the way that they were intended to be used, spinning the car wheels over and over, opening the doors over and over, stacking blocks and then taking them down, and then stacking them up and then taking them down, instead of building with them in a functional way. So all different kinds of repetitive behaviors that we might see. These emerge early on and can persist into adulthood, although Leona might want to speak to kind of how adults learn to cope with repetitive behaviors as they get older.
Absolutely. A lot of adults have learned to hide their repetitive behaviors, or like I have lots of adults that are like, I do it in the morning before I go to work to try to get it out of my system. And then like at lunch, I might do this. And then I do it when I come home, because they know that unfortunately society can be very judgmental about those behaviors. So they avoid doing them, or they find ways to hide them, or kind of make them look a little bit more typical. I know many autistic adults are so happy with the embracing of fidgets that has happened, because now that many people use fidgets for anxiety, for inattention, for focus, there is sort of this normalization of using things like that. So a lot of them have tried to move repetitive behaviors to more socially acceptable fidgets.
Yeah, great. The second symptom is rigidity or resistance to change. And so this can show up in a couple of ways. One is resistance to anything that is new or different. And so a lot of individuals with autism might become a little bit distressed or very distressed when there's a change in their schedule, or they have a substitute teacher that they weren't expecting, or it's a snow day and they expected to go to school and now they can't go to school. I've had worked with a lot of families where if they try to replace or rearrange the furniture, that becomes a really big problem because it looks different. And it's just very distressing to the individual with autism. A lot of autistic individuals also might have specific rituals or routines that they like to do, and some of them might make sense contextually, like having a very explicit and comprehensive bedtime routine or routine that they have to do before they can eat that like makes sense to them but doesn't really seem to make sense to others. Or kids might have routines that are not functional or related to like a daily routine. So for example, feeling like they have to touch the wall in certain places before they can turn the light off, or having to tap things 3 times with the right hand and tap things 3 times with the left hand. And some of that has a little bit of overlap with what you might envision in obsessive compulsive disorder, but unlike in OCD, some of these routines, they're not distressing to the child. It's more like they actually want to seek them out and they want to do them because they're rewarding to them in some way, as opposed to engaging in them to reduce some kind of internal distress. So I always just like to point out that even though they might look a little bit similar topographically, the function behind them is very different in autism versus OCD. We also see intense interests that are either unusual in their intensity or in their focus. So there might be interests in topics that you wouldn't expect a child to be interested in. So for example, having a 6-year-old who's really interested in bus schedules and memorizing the bus schedules and wanting to sleep with the bus schedule under his pillow, that's not an interest that I would expect in an average 6-year-old. And so it's a little bit unusual in its focus. However, there might be interests that are typical for a child of that age. So for a 6-year-old to be interested in dinosaurs is completely typical. However, their intensity around the interests might be interfering in some way. So they know all the Latin names for the dinosaurs, like way more than an average 6-year-old might be. They only want to talk about dinosaurs. And if you try to have a conversation with them about another topic, they will find a way to bring it back to dinosaurs. Or they might not do their work because they're drawing dinosaurs or responding to math questions with facts about dinosaurs, so that it starts to interfere with their ability to get along in their daily lives. So those are some ways that interest can show up. And then finally, sensory differences, which include sensory interests, like seeking out sensory information, or sensory aversions, wanting to avoid certain sensory information. We do see a lot of sensory avoidance around loud noises or specific noises or textures. I know we all work with a lot of people who can't have tags in their clothing because that's too distracting and distressing for them. But there also might be sensory interests, like I need to seek out smelling non-food objects or stroking things that I shouldn't, or smelling people, or I've worked with a couple of kids who have like to take like radios and turn it to static and put it to their ear to listen to that kind of sensory input. There's not an exhaustive list of how sensory differences can present, because I'm always learning new things about sensory interests and aversions. But those are some of the examples of how they might present. Anything to add, Leona?
I think those are all great. And those are ones that, again, I think they persist through adulthood, but adults get a little bit better at sort of hiding it or waiting until no one's around to sort of indulge in those interests. They're not things that go away, but they might be things that the adult has to report to you rather than things you observe about them.
Overall, with restrictive and repetitive behaviors, like we wouldn't count them as diagnostic unless they really are to a level where they are interfering with the person's ability to do the things that they want to do in their lives and the things that they need to do to be successful. And also, even if they are like to that level, we always want to think about individual situations, like what harm are they causing? They're not necessary as targets of intervention if they're not actually interfering with anything. And I think like we encounter a lot of situations where people are really kind of motivated to like squash out the hand flapping or squash out the scripting. But if it's not actually affecting the person's quality of life or success, then they're not necessary to intervene on just for the sake of intervention.
Absolutely. And what we've heard a lot from autistic advocates is that many of their repetitive behaviors aren't just things that they seek out because they enjoy, but they might also be things that are ways for them to soothe, for them to regulate their sensory integration and things like that, so that when they become targets of intervention, we're actually making life harder for them rather. And, our goal might be to help them blend into society more, but it's actually making it much more difficult for them to function, to accomplish tasks, to feel sort of comfortable within their own bodies. And just as Dr. Idarola said, when I'm working with an adult, a lot of times, especially if they're a young adult, they might present with a parent and the parent has goals that are different than the individuals. And we really need to come to terms with what are goals because society doesn't like this versus what are goals because this is what the individual needs to do in order for them to live the life that they want to live. And so as we started discussing, all symptoms for autism spectrum disorder must be present in early childhood, but may not be obvious until social demands exceed the skills. And what that means is that for many parents, we'll hear things like, well, they were like that at home, but I didn't really notice how different they were until they were with other kids, because adults tend to be very accommodating of children. So you might not notice that your child is very rigid about how they play, because you're going to play however your child wants to play, because you're just there to enjoy your time with them. But once they get into a group of other kids and other kids want to play the way they want to play, and they all need to learn how to compromise and adapt to each other, that rigidity is going to show up. Similarly with this often happens with young people with autism that are very socially motivated, but off target with their social attempts. They'll often kind of skate by when they're younger, when all kids have difficulties with the social skills, but as their peers mature and get more nuanced and more, again, for better or for worse, kind of judgmental and hold each other to higher standards, that might be where they struggle more in middle school and things like that, where kids tend to be a little less forgiving. And then what we are looking at overall is, are these symptoms actually limiting how the person functions in their everyday life? And that can be something where, especially for people that get diagnosis in adulthood, there might be guilt both on the parent's point of view that they didn't see this in their child before, and also in the young person's point of view of like, see, I didn't get help, I didn't. And we talk a lot about how with late diagnosis, we often get a diagnosis when we need it. And if you didn't need it before now because you had such a supportive environment that it welcomed your differences and it helped you use your strengths to overcome any difficulties, that's not a bad thing. That's a wonderful thing and a great indicator of a healthy childhood. And late diagnosis isn't always a case of it was missed, but might be that your environment was supportive of you and you were able to function within that environment until all of a sudden you had the stress of work and functioning in the adult world, which can be very different and has its own standards. And then related to that, we hear a lot, especially from female advocates with autism. I'm just going to move our little pictures here so you can see all our words on the screen. We know that the symptoms of autism, because it is much more common in boys than it is in girls and in males and females, that a lot of the symptoms are oriented towards what especially American society thinks of as abnormal for masculine behavior. And so when we think about what the symptoms look like in girls and women, we need to look at it a bit differently. And this is where advocates have done a phenomenal job talking back to professionals about how they've evolved, how they see the symptoms changing as they've grown up, what helps them get diagnosed versus led them to kind of float under the radar for longer. And so girls and women with autism are often described as different, but not disruptive. A lot of times when we're young, those disruptive behaviors are what's going to be the big red flag that waves and gets a diagnosis early. And this is where a lot of young women and girls get diagnosed later in life, because they're different, but they're not disruptive. So they do tend to be much more socially motivated, and they camouflage or wear a mask is oftentimes the word we hear, where they are working very, very hard when they are at school to be like their peers. And then they report this huge cost that they come home and they are exhausted and they are worn out. And it has a huge effect on their self-esteem as well, because they feel like they're always masking who they are to be someone who's more presentable to society. With nonverbal communication, again, girls and women are more likely to try to put on those facial expressions. This is where, rather than being flat, they tend to be more exuberant in their facial expressions, where then it almost goes the other way, where it's too strong, it's too much. And again, with reporting lots of discomfort and exhaustion after social exchanges. For play and friendships, a lot of times women with autism tend to have very intensive friendships with just one or two other people, and they do a lot of letting go of slights, letting go of friends kind of dragging them along and making them do things they don't want to do, sort of thing, in order to preserve friendships. They might have learned very early on that they just have to like what their friends like. And so they'll try to be very overly accommodating of their friends sometimes. Girls, their repetitive behavior tends to be less intensive and disruptive than boys. And again, I think that's because whether you have autism or not, there's that societal pressure, right? That girls just behave themselves, that they're quieter and things like that. In terms of rigidity and resistance to change, I feel like it's almost the opposite, where society likes to say that girls are high strung and girls are fussy and high maintenance. And so there's a little bit more acceptance when girls are rigid and have their little rituals. And so that might not be picked up as a symptom, because that's just how girls are. A lot of women with autism and autistic women, their interests tend to be things that are accepted as intensive. You know, we think of fangirls as being extremely intensive, of decorating their whole room with their interest. But that can be that kind of intensity that we think of when we think of the level of intensity for diagnosis, where it's starting to interfere. Their interests also tend to be less quirky, and again, just much more intensive, where they're reading all of the YA books, and maybe they're reading their book under their desk in class instead of doing their classwork. And again, that's less disruptive to the teacher, and so it's not noticed as much. They get, and another more common interests are art and animals and activism and things where it's sort of, again, more accepted for people to be very passionate about this. And then in terms of sensory differences, we see girls that just want to wear sports clothes and they're called tomboys, and no one's recognizing that there might be a sensory component to not wanting to wear structured clothes. Or we might see women that really value the sensory experience of doing lots of skincare routines and doing their hair routine, and that becoming a sensory component rather than just girls having fun and pampering themselves. There can be both aspects to that, but something we see and hear reported, of course, much more often in women and girls with autism around the spectrum. Also watching those videos on YouTube over and over and over again of makeup application and things like that. And then as we brought up, diagnostic assessment across the lifespan is different, not just because symptoms change over time, but because the goal of assessment can change over time. So in childhood, typically parents bring concerns to a pediatrician or mental health professional and determine if a full evaluation is warranted. These concerns might come solely from the parent. They might be brought up by teachers and relatives that are trusted and know the child well. But then the evaluation is done to hopefully create access to individualized intervention, whether that's in school, complementary services, a formal diagnosis by a psychologist or a specialty pediatrician. It allows for access to those service systems that can pay for a lot of those services that open doors. When you're getting an evaluation done in adulthood, especially for people that have gone their whole life without an evaluation, a lot of times there's, again, a cost-benefit analysis that needs to be done, whether you need a formal diagnosis or if a self-diagnosis of identifying as someone on the spectrum is sufficient. So again, for people that feel like they need access to funded services and supports, or for maybe an adult that has an intellectual disability, and that's always been the primary diagnosis, but now we feel like some of their behaviors are better described as autistic, and that would help them access more specialized services. It would help providers understand them a little bit better. Those are a lot of reasons to go through the long process of getting a formal diagnosis in adulthood. Whereas a lot of people where they are happy with where they are in life, but they've always felt like they're a little bit different, or they've had questions about why things have seemed to be harder for them compared to peers. Going through a formal diagnosis, which can be very costly, is always very time consuming. That might not be the best plan for them, whereas it's very respected in the autistic adult community for self-diagnosis to be honored, and to identify as neurodivergent and on the spectrum is something that is embraced in that community. And that's a really beautiful thing to see, that they're gathering together, they're lifting each other up and supporting each other. And so that is where, if you think that you have, if you're a mental health professional and you're seeing an adult, that's something where you can work through with them, like, what would self-diagnosis look like? What do they think their symptoms are? And then what does it mean to reach out and be a part of that community, and without the need for getting, an official stamp on their medical record that says this. And then, of course, we have some common misconceptions of autism. And so we do want to lay out that many of these myths are based on one stereotype or another, are based on sort of what we think of as the classic symptoms that now have evolved over time. But the most important thing to remember is that individuals with autism present themselves in as many different ways as people without autism. They're just as diverse, they're just as unique. And so it's not true that all individuals with autism are not affectionate. Many, many individuals and kids with autism have strong relationships with family and friends. That's more common than is not having any affection. It's not true that they don't understand what others are saying. Throughout their development, their receptive communication for some individuals may lag behind their peers, but overall, all individuals with autism develop communication skills. They might not be traditional verbal skills, they can vary hugely, but they're all developing ways to understand the world around them. Not all individuals with autism have extraordinary memories or other skills. It's not actually more common in ASD than in the general population. I think it can be more memorable because people are often looking for strengths, and that's wonderful. It's always a good thing to look for strengths, but we can't assume that every child with autism is going to have a very intense memory or intense talent in something. Children with autism often tend to develop their skills very unevenly rather than evenly. They might develop, as it says there, nonverbal problem solving much more rapidly than they develop their verbal problem solving because of those delays in language processing and things like that. So their skills often tend to be a lot more splintered, and that's where it can be very important. Rather than just look at one holistic picture of the child, we really need to look at different skills and different aspects of them, and look at them as one whole person rather than as one label. And then, of course, with their empathy, there's a common misunderstanding that, oh, they don't have empathy, they don't feel or understand emotions. They do. It's often about expression of emotions and how they express their emotions differently, and how they interpret other people's emotions can be different. It's not a lack of empathy, it's a difficulty or difference in how they express it. Anything to add there, Dr. Iadarola?
Yeah, I would just say that I think like you'll hear some autistic adults too talk about how they actually feel like they feel emotions more deeply than neurotypical people, and that if all of us felt emotions that deeply, we wouldn't know what to do in those situations either. And so that's why their behavior might outwardly, expression-wise, look like it's uncaring, because they're just so internally overwhelmed.
Absolutely, thank you. There are many associated conditions with autism spectrum disorder, and by associated, we mean that there can be a very high overlap, but these are, of course, they're not unique to autism, but they're things that many people with autism may also face. So many people with autism also have an intellectual disability. There's about, I want to say about 35% of individuals on the spectrum also have intellectual disability or fall in that range in regards to IQ. That does shift through the lifespan, partly because of IQ being changeable until about the age of 8. It also shifts because of how diagnostic criteria has shifted over time and when people may have been diagnosed through the lifespan. There's often a developmental or a genetic disability that can overlap with that. Again, that might be something that resolves over time. So they might have been identified as having a developmental disability when they were very young, that they are then able to catch up in terms of skills because of intervention, or it might be something that stays with them through adulthood if it's associated with a genetic condition. There are often motor and adaptive differences. So again, like differences in both coordination in terms of fine motor and in gross motor that can lead to adaptive skill delays and difficulties with their everyday use of their skills. A lot of times we see kids with autism know how to do something in one circumstance and have difficulty transferring that to other environments. There's a very high overlap of kids with autism also having ADHD, and adults with autism for that matter. They're also more susceptible to develop anxiety and depression. Executive functioning problems, which we'll go into in a little bit, are very common for individuals on the spectrum, as well as language delays, seizure disorders, sleep problems, different GI problems, and feeding. So selectivity with food as well.
One of those associated conditions that we did think was important to dive into a little bit is executive functioning. You can go to the next slide. And I'm sure executive functioning is a familiar term, and that the ways that it shows up for individuals is very familiar to all of you, but we did think it was important to kind of talk about in the context of autism, and also just, you know, in listening to this, thinking about how that can affect like a therapeutic relationship too, and progress that you can make in a mental health setting. So, you know, our executive functioning skills, our higher order brain processes allow us to do a lot of things like planning in advance and following through with those plans, keeping track of our stuff, but then also organizing internally our thoughts and how we make sense of the world, how we use working memory, and how we control our emotions and our impulses, which kind of leads to this either I'm good or not good at filtering the things that I do, the things that I say, and how I feel and how that shows up on my face. And then understanding how what we do impacts others, the perspective taking that allows us to really evaluate how we affect other people, and then whether or not we change our behavior based on the effect that we're having on other people. So, you know, these things are very common in kids with autism spectrum disorder. Not every kid with ASD or a person with ASD is going to show all of these, but most autistic individuals do have difficulties with aspects of executive functioning. However, executive functioning difficulties in themselves are not diagnostic. They're not part of the diagnostic criteria for autism because they're so common in other conditions as well, right? So we often are thinking about differential diagnosis in autism spectrum disorder, ADHD versus ASD. You can see some executive functioning difficulties in kids with anxiety and individuals with depression, right? And so it's important to not just look at these types of difficulties and naturally assume that that's related to autism, because it could be, but it also doesn't have to be. You'll also notice that some of the ways that the characteristics of executive functioning difficulties seem to have some overlap with diagnostic criteria for autism, right? So if you have a difficulty understanding how your behavior impacts other people, is that due solely to an executive function deficit, or is it due to kind of this lack of reciprocity? And those things might also both exist at the same time. And so that's why it's really important that we take the whole picture of a person when deciding whether a diagnosis is important or not. But in the context of intervention, at some level, like, it doesn't matter as much where it's coming from. It's about working with the individual to find out the best way to address that issue with them. I will say, just to harken back to something that Dr. Oak said earlier in reference to social reciprocity and repetitive behaviors, is that, you know, executive functioning is really critical for us to just like do the things that other people expect us to do. And so deficits in executive functioning, we've all seen this, right, can be frustrating to those around us. And especially with kids, I do think that often in autism, executive function deficits are interpreted as willful defiance and oppositionality. Like, you will hear people use those terms a lot with respect to the behavior of kids with autism. And so sometimes it can be helpful to have like a frank conversation about how much of that is related to the way that their brain works, and how much of their behavior or this willfulness is related to their fundamental difference in understanding of social reciprocity and emotional experience and social relatedness, and is beyond that person's control. And that sometimes can help family systems or educational systems kind of just look at it as it is and move on, rather than taking it personally or trying to address like the underpinnings of those types of behaviors. And also just allows them a framework in which to see the child more positively, rather than assuming that everything that they do is deliberately defiant.
Absolutely.
Anything to add, Dr. Oakes?
That I think that aspect of when we accept that their brains are different, so we don't take things personally, we don't think things like, well, they just don't care, or they just don't want to. Oftentimes I hear, I want to, I can't get myself to do it, or I don't remember. And like, and it's very much where it can be so damaging to the individual's to their self-esteem and to their self-image, because they keep hearing this negative view of them as, you have to care more and you have to try more and you have to do more, and they don't get that understanding that their brain is just different, and it doesn't matter how much they care. If that connection isn't there, it's just not there.
And a lot of individuals are never asked whether those behaviors are within their control or not. Like, it's very interesting if you just explore that with somebody, you know, the relief with which someone will be like, yeah, no, it does. It feels completely out of control. And I know that it's not right. And I feel bad about it after, but like, I don't feel like there's anything that I can do about it. And like, that kind of understanding that motivation to change, right, can be such a powerful tool in therapy.
Absolutely. Absolutely. And I think it can be very tricky, because executive functioning also varies widely based on things like how much sleep you got that day, how your emotions are doing overall. So what we also see is families say like, but he can do it sometimes, but not always. And that sometimes they feel like that's indicative of, so therefore it's on purpose when he doesn't. And a lot of times I'm like, that's an even bigger sign that is executive functioning, because executive functioning varies widely and is hugely affected by sleep and food and energy and mood. And so, you know, a lot of times I hear, well, he only does it when he's at home. And I'm like, because he used up all of his executive functioning energy at school. So he comes home and that's his safe spot. And that's where he's used, like, his energy is gone. So all of those executive functioning powers have been used up. If you think of it as like a battery that gets charged every night when we sleep, and then he drains it at school because he does such a good job at school, and now he's home and he doesn't have it. All right. But if you've sat in on this and you've enjoyed hearing about autism, and you think that diving into depth on case presentations, on some didactics about how to provide the most evidence-based mental health care to individuals with autism is something that you'd like to engage more in, we do have a Project Echo that is being organized. So Project Echo is all about linking together experts on a subject with people that are seeing patients or clients with that, whether it's a disorder or a condition, but that don't have that expertise, but don't necessarily need that level of expertise. One of my favorite things to say is like, I'm one of the only people that does what I do, but that doesn't make me special. It just means I have to train more people, because other people can see individuals with autism and give them this wonderful evidence-based treatment to help with any associated mental health conditions. So we'll be focusing on some of the most common mental health conditions like anxiety, depression, difficulties with executive functioning and relationships, a lot of things that we've started to touch on here. But go into how do mental health providers really work with individuals with on the spectrum so that they're getting the best care and so that they have more access to care. Because we know many people that feel like they don't have expertise in autism might feel very hesitant to take on patients, or may take on patients and realize they have autism and think, ooh, should I send them somewhere else to someone else who might specialize it? And we're here to say, no, you can support those clients that you have that have autism, and you can support them through the Project Echo, which will teach you specific skills, but more importantly, we'll have case presentations that we can collaborate on and talk through what are different avenues of our approach, what are different skill sets to use, what are services that are available around you and resources. So that is what a Project Echo is all about. And if you're interested in it, as we said, it's a team of experts on ASD. We'll be meeting for 1 hour a week, every other week. So bi-weekly virtual meetings. It'll be here on Zoom. And as we said, there'll be didactic trainings and case support. And I think the biggest benefit is the development of this professional network, where you'll get to meet other providers that are working in the community that have cases similar to yours and build that network together where we can all do some great peer consultation. And so if you are interested in that, please contact our wonderful coordinator, Jennifer Ward. Her email is there at the bottom. Thank you so much for listening and staying with us throughout this.
I'll just have one clarifying point because it's not showing up in formatting, that it's Jennifer_Ward at urmc.rochester.edu in case you want to get in touch. Thank you, Dr. Oakes, for this collaboration today, and thank you everybody for participating in this brief session.
Thank you.